back on Morning Line. Our guest with us this morning, Clint Kelly, malpractice attorney here in town. Good to have you on. It's a pleasure. Every time he comes on, I learn something from him. This guy can tell stories. The number is 737-7587 if you want to jump in. Question for him. And we've got actually Stephen here. Stephen, good morning.
Yes, sir. How are we doing today?
Good. How can we help you?
Okay, my daughter had a kid a few months ago, my first grandson. During the labor thing, the doctor used the forceps or tongues to pull him out and ended up fracturing his skull real bad.
Oh, gosh. I thought they stopped doing that.
Oh, go ahead.
I'm sorry. Go ahead. I thought they stopped doing that. I mean, a lot of kids in the old days, they'd use forceps to pull them out, and they ended up getting epilepsies, things like that. So he had to use forceps to help extract the child from your daughter?
Yes, sir.
Okay.
And doing so, he ended up grabbing on the wrong side of his skull, and they grabbed it from the front of his face and the back of his skull and pretty much fractured it. And none of the lawyers are saying they can do anything because he's not severely hurt, because so far all the tests have come back pretty good. But
well, that's
she
good.
still has to take him to years of doctors and Vanderbilt and everything else. Is there anything she can do to cover any of that, or what would you think would be the best step to take?
First thing is, it sounds like your grandson is not as badly injured as he could have been, and that's a great thing.
Yeah.
When you
Definitely.
when you mentioned fractured skull, the first thing I began to think was potential brain bleed,
Right.
which would lead to obviously brain damage and a whole lifetime of complications. If it is a fractured skull without any damage to the brain, the likelihood is that your grandson will make a full recovery. And that there won't be any need for future medical care beyond the vigilance and monitoring that's being done now. So in answer to your question, Stephen, I would just make sure that he continues to see who he needs to see to monitor this and make sure he's healing properly, and hope and pray that he continues to make progress and not have any significant damage. And if he does, I don't believe I would sue the doctor under those circumstances, because you dodged a bullet.
Okay, well, exactly. If there aren't the problems there. Now, an infant's skull, as we know, at the point of birth is pliable. That's why, to come out the birth canal, that it moves, it can be soft. But I wonder about standard of care, and you and I aren't doctors here, but I did not know that they're still using forceps, and maybe in some conditions they do, but to me, they got away from that for the simple reason this kind of crap happens.
Well, there's different ways to do it. There's also what's called vacuum delivery, where they will put basically a hood on the top of the head, and they will pull the child out with this suction device to pull through the canal. There is still forceps delivery.
Okay.
And there is a place for it in the delivery of children, but obviously it has to be certain circumstances that would justify it. I don't know if this is the case, but it sounds like Stephen's grandchild is going to make a good recovery.
And that's really the most important thing on this. But even though they'll have to be monitored, you watch it. Now, this makes me think of the case. It's a little different, I know, that we did a story on, which was the infant that was delivered, and they did the condition with the tongue. They did some surgery there. Now, we believe that child, now there was a cutting done there, okay, and they made a mistake, obviously, the wrong baby, so that clearly was actionable. But you're hoping that the child's not going to have a problem talking down the road, but you don't know, though, right? So do they know in this case? I mean, you don't know for sure.
The difference is, in this situation with Stephen's child, you would know early on if there were a brain bleed.
Okay.
You would see it, you do an MRI scan, you'd see consequences of it. And it doesn't sound like that's the case here, and that's great news. With the child who had the frenulectomy or had the surgery on his tongue, it may be some time before we know for sure whether or not he has any residual problems. I'll tell you who does have residual problems, Nick, is Mama.
That's what you're telling me.
Mama's the one who's got the problems because of what happened. This is it devastated her, and she's had great difficulty getting over that. Who wouldn't? Yeah,
just for those of you, if you've watched this show, you know what case we're talking about, and I did a story on it which actually went national big time. I mean, a lot of people picked up, People magazine picked it up. This was a case where they went in to deliver the baby, right? Well, Clint, you're better at telling again the story. They went in as, joyous time, right? Everything should be cool. Baby gets delivered, and what happens?
Uncomplicated delivery, and mom and dad are in the room, and nurse comes and gets the baby and takes the baby for what Mama believes is just going to be a pediatric examination. And they bring the baby back, and she looks in the baby's mouth, and the baby's got what looks like canker sores and bleeding around the tongue. And she asks what happened, and the nurse walks in, looks through the paperwork, and kind of does a double take and says, you're going to need to talk to the doctor about this.
Oh, boy.
And sometimes shortly after that, the doctor calls and says, I'm sorry, I mistaked your baby for another baby and did this procedure. So you can imagine what the mother felt like learning that a doctor had performed an unauthorized procedure on her baby.
Yeah, that procedure, a frenuluectomy, as he said, was when sometimes the skin's a little too tight under the tongue.
Right.
They snip that piece of flesh under your tongue to loosen it up. Now, this child didn't have that problem. And so they did that anyway, and the question is it going to affect their speaking down the road? And hopefully the kid will be fine.
Yes, exactly.
But they don't know for sure, right? And
they don't know for sure, and one of the things that we're trying to establish in this case is how did this happen?
Okay, yeah, and that's
and
the big
how
question.
Can it be prevented in the future so another mom and dad don't go through something like this again?
And one thing you said that's happening more and more now is they're not taking babies. More hospitals are shifting to leaving the baby full-time in the room with the parent, as opposed to taking him to the maternity ward.
Correct.
Where sometimes, you could grab, I guess, the wrong baby. How that happens, I don't know. But is that happening more and more in hospitals now?
I don't know about, well, I know that there's a movement afoot to establish this as the way that we're going to treat children or babies from here on, is to leave them in the room. It started with babies being stolen from the hospital for a variety of different reasons. And so the idea was, if you keep the baby in the room with mom and dad, you have virtually eliminated the risk of the baby being stolen. Well, now carry that forward. If the baby stays in the room with mom and dad, you virtually guarantee that when the doctor comes in to examine the baby, that the doctor's not going to do something to the baby that's unauthorized.
Right, and by the way, we're not saying the baby, because we understand the mother needs some sleep. It's not with the mother in the bed, but wheel in the cart, right? Where the baby's asleep in the little incubator next to the bed.
Right in the bassinet. Sit right there with them, or right with mom and dad, and there's your baby.
Okay, all right. And you just, as you said, the nurse in this case, and by the way, you said the mother's having more of a tough time. An update is the baby's doing okay as far as we know.
As far as we know,
the mom, it's traumatic for her, and I understand that. But the nurses play a role. So when we went to the break, I was saying more and more, I have nurse friends of mine who kind of talk about they're doing everything now.
Right.
Nurses are playing doctors to some degree, and something comes in and they handle it, and then maybe they'll come in and call the doctor in to take a look after the fact. Now, is that? Where is it that they shouldn't be doing it? Are there certain things that the doctor needs to have to do?
Yes, but I think the key component that gives a lot of people concern is the issue of complications.
Okay.
Let me give you just real quickly. How does a doctor see more patients? Get more people to help the doctor see more patients, meaning what they call physician extenders. Get more nurses to do more things that were traditionally done by the doctor, and then the doctor will come in for something that the nurses can't handle. But what's happening now is you've got nurses doing more and more things. They're making more, particularly nurse practitioners. They can make a diagnosis, they can render treatment, they can order medication. The problem is many of them are not trained adequately to handle complications. That's where the doctor's experience and judgment comes to the forefront, because they're trained to handle these complications. A lot of your nurse practitioners are not. They're not trained well enough, and so when a really bad complication happens, they don't know what they're doing, and they don't have, guts isn't the right word, they don't have the freedom, they believe, to just simply call the doctor and get the doctor's help, because the doctor has trusted them to handle these things. The doctor may be doing something else, and so they'll take a stab at trying to handle the complication.
Their own judgment, and could be wrong.
Correct. There's a point where the healthcare practitioner has to know his or her limitations.
Yeah, and where's that line? Because I'm just wondering, I know health practitioners have some education, but nowhere near as much as what the doctors have. Now, they have on-the-job training, and maybe they've seen the doctor and they've learned it, but I mean, how much more training does a nurse practitioner have than me spending a month with a doctor watching what he's doing and then me starting to do it? I'm just saying, I know they're more qualified than me, but my point is, where is the law where, okay, a nurse practitioner can't do that and I can't do that? I mean, you know what I'm saying? How do you know when they go too far?
That's the problem we have, is you have to look at that's where experts come.
And the problem is, as a patient, I sure don't know when I'm in there. And this nurse is saying, oh, okay, I can do this, I can do that. And I say, okay, fine. They can give me my shots, right? Draw my blood, take my temperature. Can they prescribe?
They can. Where you have a problem is if you have surgery and you're bleeding into your spine, and the nurse practitioner is making a determination of whether that has occurred and how to treat it. as opposed to the surgeon who does this all the time and knows exactly what he's supposed to do. That's where you start really getting into some trouble. And more, this is going to happen more and more medicine, Nick.
And what will the result of this be? As we see more nurses, so are we going to see more mistakes?
You're going to see more malpractice. More and more malpractice is going to come from this.
And then who is the doctor the one that answers for that, or is it the nurse? Because the doctor gives them the responsibility.
The doctor, ultimately, the buck stops with him. But the nurse is the one who's going to have his or her care examined and scrutinized for mistakes that are made. And of course, the doctor's going to say, look, I trained this nurse to handle this, and she was supposed to do A, B, and C. And the nurse will say, look, I was trained to handle this. And then you start looking at their training, and you realize they're really not well trained to handle complications.
And I'm guessing in a lot of cases they're afraid to say anything to some degree that they're uncomfortable because they want to keep their job. The doctor's training them. There's other nurses willing to step up, and so they kind of just roll with it.
Yeah, I mean, the nurse has to have the freedom to call the doctor when she begins to get underwater.
Right.
Okay?
Right.
And say, look, I need your help. Come in here and deal with this because this could be a dangerous complication. I'm not talking about something that's minor. I'm talking about something that could be life or death. You've got to have the freedom to call the doctor and say, you need to get in here and take care of this because I'm concerned.
Okay, and we're talking about stuff that happens in a lot of times in the emergency ward? I mean, I'm saying emergency.
Room, surgical suite, even in an outpatient setting. I mean, Nick, it's everywhere. I mean, when you go to a doctor's office nowadays, what are your odds of seeing the doctor as opposed to a nurse practitioner?
Oh, they come in like just for a physical. You said you're going in for one soon. Last time I went in, you know, the nurses are great, and I love my doctor. And Dr. Gaston will come in, and we'll talk, and he's wonderful. He's old school, you know, and I like that.
Yeah.
A good bedside manner. He'll talk to me, but he comes and does a little, and then he's gone, and the nurses take care of everything else, and that's fine because I trust them all. But I do see him, and I spend some time with him. But I wonder if that's the case. I mean, how long do doctors pop in? Real quick. I don't know.
Everybody has that experience of a fairly brief visit with their doctor, and in some cases you don't see the doctor at all. I mean, you got emergency rooms now that are manned by nurse practitioners who are doing the triage, basically the frontline treatment, in some instances, all of it.
It's a cush gig to be a doctor in that situation, even though maybe you're putting yourself and your patients at risk. Because I have a nurse friend I was talking to this weekend who said there's resentment building up in the office because the nurses are doing so much, and they make an eighth of what the doctor makes.
Right.
And the doctor's back there cooling his heels, he or she, with their feet up on the table doing gosh knows over records. And the nurses are doing all the heavy lifting. And they mean well, and they're going to try to care. And they are getting paid a fraction of what the doctors are. And doc ain't doing much on most of this basic stuff.
That's right. I mean, that's modern medicine, Nick.
Yeah, that's great. Let's take. Do we need to take a break first? Should I take another call? Okay, we'll take a break first. Come back with more calls. Final segment with Clint Kelly right after this.